Hello everybody. I would like to introduce the concept of focused echocardiography for you as a beginner, and I hope you enjoy the lecture and you find it very easy, very simple approach. From the first look, I'm sure you will be afraid from the echo machine or from the echo concept, because most of the time it is done by experienced cardiologists, but in fact now with advancing technology, availability of the learning materials, you will find echo is very easy, very simple to learn in a limited time and even with minimal training. So I will talk initially about simple applications that at the end I hope you will enjoy and love echocardiography. So my objectives in this talk really to introduce to you that very limited or focused applications of echo that will benefit a lot and be very useful in the clinical settings, in the emergency department, critical care, and in the duties. I will give you a hints regarding some ultrasound settings and what are the standard 4 views of echoes that you have to master and show it to others to convince them or to relay a message, and we will talk about some cases in between. In fact, you can use any probe for the echo, but this is the best probe that you will get the best image with, which is called the phased array probe. It is small footprint and low frequency. The advantage of this probe that the waves can penetrate in between the ribs and you can avoid the rib shadow in order to avoid some artifacts. Now, one thing I want you to keep in mind that the probe marker is toward the right side of the image, as opposite to the routine ultrasound way, which have been trained so far that the marker should be toward left side of the image. That means it is toward the right side of the patient. But here in cardiac setting, now cardiologists use to make the marker toward the right side of the image. That means it is mainly toward left side of the patients in some views. As far as you are sticking to the ways that we will teach you, you will have no problem in acquiring the images. Now, patient position, you can do it while the patient supine, but in some patients it will be better to have the patient tilt to the left lateral decubitus in order to improve the quality of image and get better details of the structure, especially in obese patients, COPDs, and sometimes even in thin, slim patients. Now, in terms of transducer position, where you put the probe, I would like you to memorize only 3 positions. Subxiphoid, which is just below the xiphoid process, parasternal, which is just left side of the sternum, and apical view. Now, we will start with the parasternal window. In fact, the parasternal window is the easiest window to get most of the patients and will give you most of the answers you are looking for. Now, the position is just to the left side of the sternum, basically from the 2nd to 5th intercostal space. You have to start from up going down until you get the best image. And it's just to the left of the sternum. And keep the pointer of the probe toward the right shoulder. Now, in this way, you are transecting the heart in longitudinal axis. That means you are cutting the heart through the left ventricle longitudinally, the right ventricle, left atrium, and ascending aorta. And of course, this is the aortic valve, and this is the mitral valve. And this is the same image you will get in the echo. Left ventricle, left atrium, right ventricular outflow tract, and of course, this is the posterior wall of the left ventricle, and this is interventricular septum. Now, this is the dynamic image you will get. This is the best image you have to look for, or you have to adjust your probe in order to get same image. Left ventricle, left atrium, mitral valve, ascending aorta, aortic valve, and this is the right ventricular outflow tract, or just the top of right ventricle. And this is the descending aorta here. Now, this is the parasternal long axis view. Now, if we move to the parasternal short axis view. That's mean without moving the probe, just at the same position, we just rotate the probe 90 degrees. So the pointer, instead of pointing to the right shoulder, now it will point to the left shoulder. And in this way, you are going to transect the heart in a cross-sectional view along the left ventricle and right ventricle. And this image, what you will get, this is the left ventricle and this is the right ventricle. And this is what it looks in echo. Now, in this view, you have to keep in mind that different level give you different view. Now, at the left ventricle, if you tilt the probe to point toward the base, you will have a view at the aorta. If you tilt up a little bit, you will get a view at the level of mitral valve. If you tilt more, you will get a view at the apex. And that's essential examination when you are examining the left ventricle for any pathology. Now, this is how it looks at the base. This is the aortic valve with the 3 cusps. This is how it looks if you are looking at the mitral valve. So this is looks like a mouth of a fish, so they call it fish mouth view. So you'll have mitral valve, left ventricle and part of the right ventricle. And this is how it looks at the base of the heart, a very small cavity. Now, what are the advantages of parasternal view? In fact, parasternal view, as we said, is the easiest window you can get and can give you answers regarding the estimation of global left ventricular contractility. So, does it contract well or not? Is there pericardial effusion, yes or no? And what are the right ventricle size compared to the left ventricle? What do you call it, RV-LV ratio? Now we'll start with global LV contractility. And again, here we are training ourselves, just subjective description of how contractility looks like. We are not estimating the ejection fraction, and you don't need to do it in emergency and critical setting. What you need to do is, or what you need to know, is the heart contracting well or no? And that's, you will learn by just eyeballing or just a gross observation of the left ventricle, how it contracts, and we will come to that. So this is the long axis view or parasternal long axis view of the heart. So again, you are transecting longitudinally. So this is the left ventricle, left atrium, ascending aorta and right ventricle. Now, there are 3 points you have to keep in mind. First of all, you see this is the normal contractility. This is the wall of the left ventricle. You see they are contracting and all contributing together and bringing the cavity smaller. So the whole muscles are contributing to the overall contractility and the cavity becomes smaller during systole. Second point is that there is thickening of the muscles during systole. So once the ventricle contracts, you will observe that the muscle thickness increase. Third point, this is the mitral valve. This is the posterior leaflet here. This is the anterior leaflet. And you can see that the anterior leaflet almost touches the septum during opening. So the mitral valve open fully and the leaflet touches almost the interventricular septum. So these 3 observations, you will find it in normally contracting heart. This is how it looks in short axis view. So you just rotate the probe for the pointer to be pointing toward left shoulder. Again, you'll see the whole left ventricular wall are contributing to the contraction and brings the whole muscle toward the center of the ventricle. And there is thickening of the muscles during systole. So this is a normally contracting heart. Now let's take this case. I'm sure most of you have been across such cases. Young patients who come with dyspnea. And he told me that he has shortness of breath since 1 month. And somebody told him that your dyspnea is secondary to bronchial asthma. So he came to the ER asking just for Ventolin and he will go home. vitally were stable, apart from just examination wise he has some bilateral wheezes. So we take a chance to just look to his heart, how it looks like. This is parasternal long axis view. You see this is the left atrium, left ventricle. So what do you notice here? Yes, you see the walls of the left ventricle are not contracting well. There is no much thickening during systole. In fact, it's barely moving at all. The cavity did not change diastole from systole, so it's almost not moving. And you see the mitral valve is far away from the septum, so it is not opening well. So these three signs are indicating very severe left ventricular systolic dysfunction. So this contractility is very poor. So this is how it looks in short axis. Again, this is the left ventricle. RV is not shown here, but should be here. It's the mitral valve. You see the cavity is not changing during systole and diastole, very minimal change. And there is even minimal fluid around it, around the heart. Even here there is minimal fluid. So this is severe left ventricular dysfunction. In young patient, most likely it's cardiomyopathy. So his dyspnea is not secondary to bronchial asthma. His dyspnea is secondary to congestive heart failure. And here the echo in less than 60 seconds can give you the answer and can change the management 180 degrees. Now compare that to this patient. How the contractility looks like here. Now these patients come to you with hypotension. You see the heart is contracting vigorously and the walls of the ventricle are almost touching each other. Here the ejection fraction is almost very high. So all the blood is ejected from the left ventricle. So the cause of shock here is not the heart. That means the heart contracting well. But the problem is possibly hypovolemia. You will find this in upper GI bleed, hypovolemic shock to any other cause, thyrotoxicosis, fever, any hyperdynamic circulation in fact. And you have to compare that with normal, just for comparison. So you have to train your eyes to pick up normal contractility, hypodynamic contractility, and hyperdynamic contractility in order to help you decide about the dyspnea, about the hypotension, and it can change your management accordingly. And this is again how it looks in short axis. This is hyperdynamic circulation, and this is again hypodynamic heart or severely hypokinetic or hypodynamic, poor LV dysfunction or severe LV systolic dysfunction. Now we'll move to the second view or second position of the transducer, which is the apical 4-chamber view. Now the apical 4-chamber view, the position of the probe is just below the left nipple or below the left breast in the female, and the pointer of the probe should point to the left side of the patient. Then you can adjust, either rotate, tilt or rock until you get the best image. And this view will transect the heart through the 4 chambers and will give you a view of the 4 chambers of the heart. So you will see the left ventricle, right ventricle, right atrium and left atrium, and of course will show you the mitral valve and the tricuspid valve. Now what this view gives you, in fact this view is excellent for most of the applications. It will give you global left ventricular function. It will answer if there is pericardial effusion or no. It can give you the RV-LV size better than the other view if you get it correct. So here we'll talk about RV-LV size. Now the normal RV-LV ratio is 0.6 to 1, or in other words the RV should not be more than 2/3 of the left ventricle, or in other words most of the time the left ventricle should be larger than the right ventricle, and that's logical because the overload on the LV is higher. Now let's take this patient, 30-year-old lady with metastatic breast CA. She presented with dyspnea, fever and hypotension. So basically she is in shock. okay, you put the patient in ER under monitor, you give her fluid, take bloods, chest x-ray, ECG, everything. So what is differential in this case? In fact, all types of shock should be your working diagnosis to start with. So septic shock, cardiogenic shock, obstructive type of shock like tamponade, tension pneumothorax, massive pulmonary embolus, anaphylaxis there. So all types of shock should be working diagnosis, and your job, your duty is to approach the patient and try to rule out most of these types until you are left with at least two or three differentials in order to limit the differential diagnosis, in order to improve your management. So echo here can help you. So let's take this echo of the patient. So this is the normal echo, just for comparison. This is the patient echo. What do you see? What do you observe? Yeah, first of all, the left ventricle looks contracting well. Second, yes, the right ventricle size is clearly larger than the LV. So here the RV-LV ratio is higher, is more than 2/3, is even more than 1:1. So RV is larger than 1:1. So here you have to expect what? You expect there is increase outflow pressure on the RV. So that means there is obstructive issue in the right ventricular outflow causing RV strain if it is acute. So one of the differential here is massive pulmonary embolism. Keep in mind other differential like right ventricular infarction as well, but it depends on the clinical scenario. You can differentiate which one. So this case echo helped us deciding about massive pulmonary embolism by just pointing to the RV-LV ratio. Of course, there are secondary signs of pulmonary embolism or massive pulmonary embolism other than the RV-LV ratio, because this itself is not specific. You have to look for secondary causes, but the scope of this lecture is just to basic hints regarding the working diagnosis in such cases. Now, the last view is the subxiphoid view or subxiphoid window. The location, again, it is just below the xiphoid process, pointer toward left side of the patient, and you try, in this case, to dissect again the heart in 4-chamber view. So, in this view, you will see part of the liver and the 4 chambers. So, this is part of the liver. Then next to it, right ventricle, left atrium, and right atrium. And again, this view can give you, again, similar answers to the same applications. Now, the correct way is to place it just superficially and to push hard for the waves to penetrate just anteriorly. In order to improve the view also, just ask the patient to inhale, to take deep breaths, so the diaphragm will come down and will bring the heart with it, and will bring it close to the view. Now, let's imagine the same case we discussed recently. Now, this case came again to you in the emergency department. It's a 30-year-old lady with metastatic breast CA. Again, she presented with shock. Same types of shock should be in your mind. Now, the role of echo is just to rule out some of these types, or at least prioritize some of these shock accordingly, and leave you with limited types, limited differential diagnosis in order to approach the patient better. So this is the echo of the patient. This is a subxiphoid view. So you'll see the 4-chamber, right side, left side of the heart. So there is an anechoic collection around the heart. So this is pericardial, large pericardial effusion. And there is right ventricle. You see it is almost compressed. So here we find pericardial effusion, isn't it? So the question now, does pericardial effusion cause any problem? In fact, pericardial effusion will not cause problem to the patient unless it accumulates very fast or it is very large. In fact, in medical cases, most of the time it is accumulating gradually and slowly, so the patient can accommodate that and can tolerate without symptoms. And if it is accumulating acutely, like in stab wound, penetrating trauma, or blunt trauma, or in cases of malignancies, even minimal amount of fluid can compress the right ventricle and cause what we call tamponade and shock. So the question is, after finding the fusion, is it causing tamponade or not? Now, keep in mind, to diagnose tamponade, you have to find some of these specific findings or more observation pointing toward tamponade. So the first finding is right atrial collapse, and the atrium will collapse in the systolic phase of contraction, or in the cardiac cycle. So this is the right atrium, and you see the right atrium will collapse at the time of QRS. So if you trace that with the cardiac monitoring, at the time of QRS, you will see the right atrium collapses. And that's logical because the pressure in the right atrium is very low. This is venous pressure. If the fluid accumulates more in the pericardial space, it exerts pressure. So if the extrinsic pressure on the right atrium is higher than what's inside, so it will cause pressure and collapse of the right atrium. Now, the next step is that the right ventricle will collapse during diastole. So if you trace the ECG during diastole, that's when in between the two QRS, you will find the right atrium compressed, again due to the high pressure in the pericardial space, and that of course will limit the right ventricle to dilate and accumulate more blood from the IVC. So it will impair the preload, and as a result the afterload or the cardiac output will decrease and cause shock. So the first step is right atrial collapse during systole, then it will advance to right ventricular collapse during diastole. Let's see how it looks like. This is again patient in shock. We find large pericardial effusion. This is the effusion. Again, this is apical view, and we see the right atrium is collapsed. Now, to decide is it during systole or diastole, we have to trace the ECG. Now, if we pause the video at the time of QRS, you will find that the right atrium is totally collapsed. So this is early sign of tamponade. Now, the next sign is this. This is Subxiphoid view. You see the right ventricle is collapsed. Now, is it systole or diastole? We know that specific to tamponade is the collapse during diastole. Now, let's track the ECG. This is the mark before the QRS. That's mean before the contraction, before the systolic phase of the cardiac cycle. We see the free wall of the right ventricle is invaginating into the cavity. That's mean the pericardial effusion exerting a pressure higher than what's inside the RV, and it causes collapsing of the RV. In this case, in fact, the RV cannot accommodate any preload, so it will decrease the cardiac output and cause shock. So this is diagnostic of tamponade. So in summary, what we have learned so far, just remember 4 cardiac view: subxiphoid, parasternal, and apical 4-chamber view. And this is how it looks in parasternal long axis view, short axis view, subxiphoid, and apical 4-chamber view. And you have to train your hand in order to get the best image. Now, pericardial effusion, this is how it looks. This is the long axis view. You will see anechoic rim around the heart, and again it's anterior to the descending aorta. This is how it looks in short axis view. Again, fluid anechoic collection around the heart. This is an apical 4-chamber view, again surrounding the heart, the fluid. And this is how it looks in subxiphoid view. Again, anechoic collection around the heart. Second question, is it causing tamponade or not? So you have to look for right atrial collapse during systole, then right ventricular collapse during diastole. Your landmark here is the descending aorta. If the fluid is anterior to the descending aorta, it is pericardial effusion. If it is posterior, it will be pleural effusion. Now, global LV function, again, you are not estimating the ejection fraction exactly. What you need to know, is it contracting well or no? This is a normally contracting heart. This is hyperdynamic heart. So, like in GI bleed, hypovolemic shock, you will find this almost hyperkinetic or hyperdynamic or working hard, really, to eject more blood. So this is hyperdynamic circulation, this is hypodynamic, this is very severe LV dysfunction, this is normal, this is hyperdynamic. So you have to train your eyes again to pick up those three entities. It's very easy to compare those three. Now, last application is to the RV strain. What is the RV-LV ratio? If you find the RV is larger than the LV, suspect outflow pressure in the acute setting, like pulmonary embolism, RV infarction. But keep in mind, other chronic process like COPD, pulmonary hypertension, tricuspid valve disease, all these can cause RV dilatation. But in specific clinical entities, if it is acute, it might guide you toward acute process like massive pulmonary embolism. So again, keep in mind that you are basic sonographer and you are qualitative. Now that's mean you are just answering, is there pericardial effusion, yes or no? Is the heart contracting well or no? And again, you are focused. You are doing the echo for specific indications. And we are not discussing like valvular lesions. We are not discussing again wall motion abnormalities, because this comes in the next step. Once you master this application, once you master this view, then you can move forward and learn how to detect mitral regurg, for example, how to detect acute ischemic insults by detecting wall motion abnormality, for example. In this setting, mainly to help you decide why my patient is critically ill, why he is hypotensive, why he is dyspneic. Is it only asthma or COPD, or there is something else? And if you combine all the history and clinical data, it can really help you in deciding about cardiogenic shock. You can rule out cardiogenic shock by observing the heart hyperdynamic or normal contractility. You can decide about fluid. Can I give him a lot of fluid or not? It can give you a hint regarding if there is massive pulmonary embolism. Can help you decide whether there is effusion or not, and is it causing tamponade or not. Can help you estimate the LV function, how the heart looks. Is it contracting good or is it very bad? And that not only will give you answer regarding the type of shock, but at least to help you choose which medication to use. For example, in some clinical cases like atrial fibrillation or tachyarrhythmia, you want to give patients drugs to lower the heart rate. Now, some medication are contraindicated if the patient have some type of LV dysfunction, like calcium channel blocker. So just observing the heart is contracting normally, that give you a green light to give those medication. Otherwise, you have to be restricted with very little choices in the medication to control the rate, for example. So if you combine all these data, the echo will give you the best of the advantage, especially in the acute care setting, and improve your patient care. Thank you very much.